Hi, I'm Dr. Noel Bairey Merz, Medical Director of the Barbra Streisand Women's Heart Center at the Schmidt Heart Institute, Cedars Sinai Medical Center, Los Angeles. We're going to talk about women and heart disease today. We'll talk about what we know, what the research has shown to improve sex-specific care for women, and we'll also be talking about future research studies. We're always looking for volunteers. Most of them are non-invasive, and we would love to hear from you about whether or not you're interested. We'll start taking some questions. The way to ask a question is to put it in the comments box.
Okay, great. What kind of work does your team do?
So what kind of work does the Barbra Streisand Women's Heart Center team do? We are faculty. We are now 3 cardiologists. We are 2 laboratory scientists, 1 vascular biology high-risk menopause physician, 2 nurse practitioners, 1 nurse scientist, and then a variety of research coordinators, research assistants, laboratory technicians, as well as imaging specialists who work to take care of women. We do advanced imaging in our center, but also help us with the research. And so we do everything from caring for women with heart disease in our clinic, conducting clinical research as well as laboratory and population-based research. And then finally, we have a very active educational program where we educate healthcare professionals, cardiologists, primary care physicians, nurses, and then we also do education for the community. We give community lectures at clubs, at synagogues, at churches, tremendous amount of community activity as well.
So how does heart health care differ between men and women?
So how does heart health care differ between women and men? We have found with our now 30-year program of research that while a number of things are similar, so the leading killer of Americans, cardiovascular disease, kills an equal number of women and men now. So that might be a shock to some of you that so many women are dying of heart disease. That wasn't really recognized previously, but it is a similarity. Heart disease and stroke is the leading killer of all Americans and increasingly a global health threat. What's different between women and men, for example, is when a woman or a man is having a heart attack, the man is more likely to experience that classic Hollywood heart attack, clutching his chest, saying that he has chest pain or chest pressure. Women will have that about 1/3 of the time. They will more likely complain of stomach upset or indigestion or shortness of breath, cold sweats, jaw or arm pain. So this would be an example of how heart disease can differ between women and men.
Can you tell me about the Warrior study?
The Warrior study is a research study that we have now funded by the congressionally mandated, medically directed research program by the Department of Defense. And so your tax dollars that are supporting this federal initiative are supporting our important need to do a big clinical trial to establish guidelines about how best to treat women's heart disease when they clearly have abnormal blood flow to the heart and they are at risk for heart attacks and strokes, yet they don't have obstructed or plugged up coronary arteries. So we cannot stent our way out of this, we cannot bypass our way out of this. Traditional therapies that work in men. If a woman is interested in participating, she needs to be 3 things. Number 1, a woman. It's a women's only study. Sorry guys. They have to have some type of above the waist symptom. Could be chest pain, could be a shortness of breath, could be one of these atypical symptoms that a physician had wondered if it was actually coming from the heart. And then number 3, they need to have an angiogram, either invasively or non-invasive, very common, that shows that their arteries are open. There's no obstructed coronary disease. Those three things would qualify a woman for participating. We have sites in Los Angeles, we have sites in Florida, we have a site in Kentucky, we have sites at military bases. So feel free to visit our website to find out about the Warrior Trial, or call our research office directly, 310-423-9666. And we would look forward to screening you and hoping that you'd be able to participate in the study. Everyone is monitored, so you would get additional monitoring. And then number two, half of the folks that enter will be randomized, flip of the coin, we actually do it with a computer, to either optimal medical therapy, which is statin, cholesterol-lowering therapy, and an ACE inhibitor. This is a medication we've had for 40 years that saves lives in women with obstructed coronary disease. So we are testing this strategy for women that don't have obstructive coronary disease because it is so prevalent and we have no guidelines.
How do I know when I should see a heart specialist?
So you would know when to see a heart specialist because your primary care physician or health provider has not been able to come up with a reasonable explanation for why you might be feeling extremely tired. You no longer can exercise. You have some type of symptom above the waist, and it might be chest pain, but it might be shortness of breath. It might feel like indigestion, be jaw, arm pain, cold sweats. And that physician has not come up with a good explanation for it. Or that you are referred, and our primary care physicians do this all of the time, refer for some type of diagnostic evaluation by a cardiologist.
What is your recommendation regarding a nutritional approach to reduce or manage women's heart disease? Do you recommend a specific diet?
So how can people manage, or at least help manage, their heart disease by nutrition, a nutritional regimen? And we use the name nutrition very purposely. People that diet often give up on the diet after 6 or 8 weeks, and it's never been shown, there's no diet that has ever been shown to reduce heart disease by losing weight. So that's a myth that we need to bust. A nutrition regimen that can help control heart disease in women and men, oh, by the way, because these have been tested in women and men, is what we now call a Mediterranean-style nutrition regimen. And that is abundant fruits and vegetables, beans, legumes, lentils, every day. A serving of fish the size of your palm twice a week. Complex carbohydrates, a single serving of alcohol if your doctor advises with a meal, and very sparing animal flesh, otherwise known as chicken, pork, red meat, and then once or twice a month dessert. So that is Mediterranean style eating. Not only has it been shown to reduce heart disease, it does also reduce cancer.
What are some common misconceptions in your field?
What are some common misconceptions in cardiovascular disease in women? Number one, that women will complain of chest pain, and when they don't, they often are ignored. So one of our advisements in the Women's Heart Center to our patients, should they need to go to the emergency room, is say they're having chest pain even if it's not, if it's just severe shortness of breath or cold sweats. If you say chest pain, you get more attention. So there's one myth to bust. Probably the biggest myth remains that women on the street, when we do surveys, still think that their leading health threat is breast cancer. Women overall now die 3% from breast cancer. The lifetime risk to get breast cancer is still 1 in 5, but we are very good now at detecting it and treating it. Where heart disease remains, 1 out of 2 women will get cardiovascular disease in their lifetime, and 1 out of 3 will die from it. So this really is our leading healthcare threat and commonly misunderstood. Please tell your friends, tell your family, and then take some action.
Okay. What are some challenges you foresee in the future?
Some challenges that we foresee in the future is the last 30 years we have made up for some of these knowledge gaps. Our National Institutes of Health has funded a number of studies as well as initiatives that have reduced the big gap. Starting in 1984, many more women were dying of heart disease than men. That was a bit of an alarm call and led to us doing research and putting into place initiatives that genuinely did save women's lives. So a future problem is going to be that we become satisfied with that. And here's why that's not a good idea. We now are seeing in the last 10 to 15 years actual rising cardiovascular death rates in young women under the age of 50. Heart attacks in women under the age of 50 are less common than older women, and yet this accounts for 20% of all cardiovascular disease in women, and it is on the rise. Cardiovascular disease deaths in men under the age of 50 is not on the rise. So this is a critically important issue that we start to understand what's going on, what are the risk factors, is it because women are not getting treated, is it because they don't get referred to a cardiologist, they are told to lose weight, which is not effective. This is one of the challenges that we have right now, and we are addressing it with research in our Barbra Streisand Women's Heart Center.
Hi, Dr. Merz. I'm a 42-year-old female. Is eating red meat once or twice a week okay for my heart health?
So for a 42-year-old female who is otherwise healthy, is eating red meat once or twice a month okay? One of the things to sort of think about in terms of any lifestyle, and that would be, trying to eat a more Mediterranean-style nutrition, which often includes vegetarian days, trying to exercise every day, avoiding smoke and not smoking yourself and staying away from secondhand smoke. All of these lifestyle activities are very similar to saving for your retirement. Think of it as saving for your life. So every day that you do it, it's a day that you put money into the bank, and it will be there for you as you age. You will age more gracefully. So is it okay to not save twice a month? That's your decision. It would be better. Your savings will be more plentiful if you try to save every day. But it's obviously a personal choice. And the more that you save, the better your health will be going forward.
Is it true that microvascular disease is hard to treat but not life-threatening?
So coronary microvascular dysfunction is another aspect that is more specific to women. If we were to research and measure 100 subjects, it would be about 60% or 60 women and 40 men. So men can get it, but it is preferential in women. It is a myth that it cannot kill you. It is a at-risk cardiovascular disease condition. It is not as bad for most people as having plugged up arteries, and yet it is bad in the sense that we realistically at this time don't know how best to treat it. So I'll circle back. This is what we are studying in the Warrior trial, and we're very interested again in speaking with women who have some persistent symptom above the waist that a physician thought might be related to her heart, and therefore she got an angiogram, either one of the invasive ones or the non-invasive angiograms are called CAT scans, CT angios. So we're very interested in talking to women about that.
Are there any new medications on the horizon for coronary microvascular disease?
Very exciting is we are also doing a trial called Caladrius. It is a proof of concept trial funded by our National Institutes of Health that evaluates women and men. Men are eligible for this study with a simple phlebotomy, which is taking your own blood and then processing it so that we grow more of your own stem cells, CD34 stem cells, that are just circulating in your bloodstream. And then we give them back. And this is a research program designed to see if this can improve microvascular function in the heart. It has previously been shown to improve small vessel function in people who have peripheral vascular disease, sometimes known as claudication. So that's very exciting, and there are new drugs that are on the horizon as well. We do not currently have one in protocol, but it's always good. Check our website and see what the studies are, because we're always looking to study women. And not surprisingly, ladies, you will find that women volunteer for research studies, and that's another myth that we have to bust, that women will not participate in studies. So we've done very well, and we have good volunteers. Remember, volunteers live longer. That is an observational statistic with research studies.
What is your favorite cardio exercise?
My personal favorite cardio exercise is the elliptical, because I now have knees that have problems, and having both parents well into their 80s with artificial knees, I'm hoping to avoid that. But for all of us at large, the best exercise or physical activity regimen is the one that you like to do, and the one that you are able and feel comfortable doing every day.
How is coronary microvascular disease diagnosed?
So how is coronary microvascular dysfunction diagnosed? 3 ways. One is invasive, where we do one of those angiograms. It's now considered an outpatient procedure, but you do have to come into our hospital or a cath center. You come in early in the morning, you usually go out around 12 noon. That said, it's an invasive study. You get exposed to some dye, you get exposed to some radiation with the contrast to take the pictures. But that is our gold standard, and we will deploy that when women are relatively young, when the treating physician is concerned about taking medication, or even whether or not they should be worried about it, often women that don't live near a center of excellence. The second way is advanced imaging, usually with cardiac MRI or PET scanning. This is non-invasive, so completely safe. Some exposure to dye and radiation, not excessive, good value if we are trying to figure out what's going on. It's not as good as the invasive testing because it doesn't demonstrate pathways that sometimes can be helpful in medication selection. But better than nothing for certain cases. Last but not least, we do empiric therapy. If a woman is older, particularly over the age of 65, if she already has some high blood pressure, some high cholesterol, or even some diabetes, she needs to be treated anyway, given the treatments that we are using while we await these clinical trials for better advisement. We actually sometimes just empirically treat people and monitor them, of course, because we need to make sure that we keep them safe and avoid heart attacks and strokes.
Do you have any tips on how I can talk to my mom about taking better care of her heart?
Well, how do we talk to our moms? Moms, of course, have raised families and are most often thinking about other people before themselves. So I think, one general advisement is what you hear when you're on the airplane and you have to buckle up, and they give you the safety lecture, which is, before helping others, put your own oxygen mask on first. See if that can get her attention. One of our most effective smoking cessation campaigns has been to ask grandchildren to ask the grandparents to stop smoking. So maybe if you've got some grandchildren around, ask them to ask her. That might be effective too.
What are your thoughts on broken heart syndrome and how common is it?
So broken heart syndrome, otherwise known as Takotsubo syndrome, is also something that is much more common in women. It's probably more 80 to 90% women, although we now are starting to recognize it in men, so we probably just didn't see it. Because it's more common, so much more common in women, and because we didn't study women until the last 20 to 30 years, it was really unrecognized until about 15 years ago. It is an entity that looks like and feels like, and everybody is convinced that it's a very large heart attack. And yet, when the woman is taken upstairs to the cath lab where we do the angiograms, the arteries are all open. So it's another open artery problem. It appears to be, in the research to date, related to an imbalance of the what we call autonomic nervous system, which is the brain and all the nerves that are controlling all bodily functions, but in this case, cardiovascular function. In women, it sometimes is triggered by a stressful event, emotional stress, but it can be triggered by physical stress. We'll see this occasionally in triathlons or marathons. And then 20-30% of the cases, there's no apparent trigger. So this is an area of intense investigation, again, an understudied area of women's health. We have a Takotsubo heart-brain study for, again, women and men that would want to volunteer. You will get a free of charge functional MRI. Yes, you have to get into the MRI, so you might be claustrophobic, so don't volunteer if you're severely claustrophobic, although we can help with that. And then you also get a cardiac scan. And then the last thing that we're doing with Takotsubo, or broken heart syndrome, is we have just launched a registry, and it is linked to our website, the Barbra Streisand Women's Heart Center website, and we are looking for volunteers to answer questionnaires about their health, as well as just who they are, age, etc., and then to give us a fingertip drop of blood for proteomic analysis. Many diseases now are actually linked to our DNA, or at least disease susceptibility. And one of the best ways for actually figuring that out is to do a protein analysis called proteomics. This is an exciting new area. We now have the capacity to do this, meaning you could live anywhere in the world and you can mail in a drop of blood for us for this type of research. So again, this is available on our website.
Okay. What is a no-CAD heart attack?
No-CAD heart attack is no coronary artery disease, and physicians and investigators are kind of infamous for acronyms. I guess we're just talking fast all the time and we don't want to say the full name. But it means that the heart attack occurred with no plugged up arteries, no coronary artery disease. We have a term for this now, of course. It's called Minooka. The medical scientific term is MI with no obstructed coronary disease, Minooka.
What causes coronary microvascular dysfunction?
Well, what causes coronary microvascular dysfunction is also an area of intense research. We have 2 protocols looking at this now. So again, feel free to visit our website and or give us a call if you think you might be eligible for any of these studies. What we are studying and root causes are, it appears that some of the coronary microvascular dysfunction is related to what we call traditional cardiac risk factors. Advanced age, high blood pressure, sugar diabetes, high cholesterol or other lipids in the bloodstream, family history of premature coronary disease, and cigarette smoking. That said, in one of our WISE early publications, it only accounted for about 1/3 of the coronary microvascular dysfunction that we were observing. So there clearly are other risk factors and other susceptibilities that are under active investigation.
Okay, this is our last question. How is estrogen related to the heart? Is it good or bad?
Well, how is estrogen related to the heart in women? And I'll say something about men as well, which is, none of us are all estrogen, and for example, men are not all testosterone. The differences between women and men are that women have higher estrogen levels, even in the menopause, than men, and men have lifelong higher testosterone levels than women, but we're all a mix. Women have low levels of testosterone just like men have low levels of estrogen. This is an important point to make because one of the first clinical trials done for heart disease, and of course in the 1950s and 60s they only studied men, they randomized men to estrogen. Because they wanted to see if estrogen would cure their heart disease. It didn't, and we don't give men estrogen for a lot of reasons. But there is no indication currently in our research that estrogen levels or estrogen replacement or estrogen supplements can benefit women's heart disease. There may be in the future clinical trials looking at very young women that go through the menopause, 40, 45-year-old, under the age of 50. That might be an opportunity to see if they would benefit as their bones do with estrogen supplements if they have an early menopause. But other than that, the guidelines currently are you will take estrogen if prescribed by your physician for hot flashes that are sufficiently distressing, lowest dose for the shortest period of time. All right, thank you for joining us today. Again, visit our website or if you think you're eligible for any of our studies, give us a call in the research office, 310-423-9666. Thank you.